Good morning. My name is Smithy, and I'm an intern, a medical officer intern in general surgery. So I'll be presenting a case that is in our ward. So our patient called HS, um, date of birth 1984, male, and sorry, I haven't. Uh, we are dealing with a diagnosis of squamous cell carcinoma of the scalp with bone involvement. He's a 34-year-old known RVD patient on heart on 3TC, D40, and efavirenz from 2007. Can you? I think it's blocking some. From 2007, and then it was changed to um, another regimen, AZT, 3TC, and efavirenz due to toxicity. The CD4 count in 2007 was 296, and in 2013 it was 410 with a viral load of 104 copies in 2014. He presented in 2015 with multiple scalp lesions and a history of scalp ulcer for over 2 years that was increasing in size with irregular margins. It was tender, not itchy, but it was discharging blood and pus on and off. The biopsy confirmed a squamous cell carcinoma. Sorry. Oh, okay. So in 28, oops, sorry. Yeah. In 2015, they did a wide excision of the disseminated squamous cell carcinoma of the scalp, after which a split thickness skin graft was followed after a month. And then he was followed up in the plastic surgery clinic, where he came in with a complaint of developing multiple scalp lesions and hypopigmented patches and papules around the left temporal area and the left ear. In 2016, a scalp tumor excision was done by the general surgical team, and the following year, the patient came in with a post-auricular mass distorting the anatomy of the left ear and another nodular masses on the scalp. The histopathology confirmed squamous cell carcinoma plus metastasis. So he underwent 3 cycles of chemotherapy, and in November 2017, he underwent wider margin excision. After 2 months, the histology again confirmed a well-differentiated invasive squamous cell carcinoma. So, so in May 2018, an excisional biopsy of the scalp lesion and the posterior trunk was done, after which he was in the ward and the ENT team had reviewed him, and they said that we will have a discussion at the tumor board. The neuro team also got involved, and they ordered an MRI brain with contrast, which showed right parietal and a frontal scalp mass with bony destruction and early intracranial extension consistent with aggressive neoplasm, a squamous cell carcinoma. And a left parotid and upper cervical mass with a differential of metastasis and parotid gland neoplasm. So he was reviewed by the hemato-oncology team, and they said that we should discharge him to KNH or Eldoret Hospital for radiation, but the patient said that he cannot afford radiation. So he is currently still in the ward, after which the neurosurgical team reviewed him again, and they said that the squamous cell carcinoma is extensive with metastasis. It has eroded the skull and infiltrated the superior sagittal sinus. So the only option was to debulk to increase the efficacy of radiotherapy. After which they said that the general surgery team and the ENT to plan for debulking. And then the ENT had said that the tumor may not be operable, and neuro said again that obviously the lesion is invading the superior sagittal sinus and there's a high risk in debulking the tumor. So the patient has no history of chronic illnesses. He's not diabetic or hypertensive. He has history of blood transfusions in the past. No history of any road traffic accidents or burns, and he has this history of chronic skin lesions since 7 years now. He's single. He works at Butali Sugar Factory, or he used to. He has no history of alcohol or smoking, and he is a NHIF beneficiary. So in summary, this patient is a 34-year-old non-IVD patient on heart, presented with multiple scalp ulcers in 2007 and generalized skin lesions. The histology showed us a squamous cell carcinoma of the scalp, and the imaging showed bone involvement. The tumor seems surgically inoperable. So on general exam, the patient in the ward at the moment was in a fair general condition, not pale, not jaundiced, not cyanosed, and he has generalized skin lesions over the entire body, which are white in color, and the papules about 5 millimeters in diameter. The vital signs were normal. So on our local exam, he has a post-auricular left-sided mass extending downwards to the neck. It is nodular, non-fluctuant, firm, and non-tender. It's distorting the ear anatomy and oozing pus and blood on and off. There's also a small protruding mass on the inner ear, which is tender on palpation, and the generalized skin lesions are also on the mass, which are white in color. So this is a picture of the mass with the skin lesions. The skin lesions are over the entire body, the way they're seen on the neck. So our point of discussion was for this patient, surgery versus radiotherapy and the associated skin lesions, which he never really got a dermatological review. So we are not sure what the skin lesions were exactly. Thank you.
Hello.
So actually, Dr. Darwin was supposed to be present for this presentation, and he had spoken to Dr. Lugaria, but seems like none of them could make it for this.
Yeah, but from what I'm seeing, the first time you said you cannot go for radiation because of finances, isn't it? Hello.
Yes.
Can you hear me?
Yes, yes.
The reason for not going for radiation initially was finance, isn't it?
Yes, that was the reason.
So then radiation is still not an option because she cannot afford radiation, isn't it?
Now the patient says that he has NHIF, and the only reason that he did not go to Kenyatta Hospital was because he's scared of the services there. He says that it's really slow, but I think he can afford radiation if he really wants to.
Yeah, because metastatic squamous cell carcinoma, surgery is usually not very easy because you must get very good margins. And once it's already metastatic, I would agree with those ones who, the ENT surgery team, which was not for surgery initially.
Yes.
So you usually have two choices. You can radiate the tumor and let it shrink. And if there's a residual, then you can think about operating.
Okay.
If that is not feasible, then you can give chemotherapy, let it shrink, then decide what to do with it later. But I don't know why you are not even thinking about chemotherapy, because if radiation is not available, then chemo is usually the next thing for squamous cell carcinoma.
Okay.
Yeah, these are just my honest views from basic principles of squamous cell carcinoma.
Yes.
Is Jesse there?
Sorry?
Is Jesse, Dr. Opakas, is he there?
Thank you, Dr. Ganda. I'm Dr. Ngoiz, ENT, and we had reviewed the patient, and we think we cannot achieve clear surgical margins in this case. It's advanced, it's recurrent, it's ISS, and he has multiple skin lesions, been recurring from everywhere. It has intracranial extension. I don't think it's operable. So I agree, we can just send for chemoradiation.
Okay.
Unless somebody else.
But why? I think the issue was with the neurosurgeons. The neurosurgeons had the belief that they needed to debulk the tumor. Basically, they're saying that they are willing to have no surgical margins after the surgery.
For
the reasoning from what I heard is that the radiation will be better penetrating. I don't know whether that's true and where that came from.
The bulk may have a role, but the last review I saw, I don't know how they're going to bulk sagittal sinus, because I saw the last said it's inoperable.
Yes.
Isn't it? Yes. It may be difficult, but
yeah, I think so.
Get a view. We can get a view from them before we go ahead.
Yes.
Yeah.
But it would be good to get the view of the radiation oncologist. Eh?
Hello, good morning.
Morning.
So sorry, Dr. Shah, just out of curiosity, where was the surgery first done? Was it MTRH? Did we have a report of maybe whether they achieved negative margins with the surgery, or whether the patient was informed of the possibility of the need for radiotherapy initially? Because otherwise, in most cases, if the tumor has involved the covering of the skull, then the patient would definitely need to be advised on radiotherapy straight from the word go. And if, sorry.
Sorry, the first excision was done in MTRH, and he was advised to go for radiotherapy initially, but he didn't because of the finance issues.
Oh, okay. So the other concern that I had was about his HIV. He seems to still have a pretty high viral load. You said 400 and something. So it would really help if the infectious disease people came and, reviewed his treatment and see whether there's need for change, and there's still need for dermatology review to just check out what those white skin lesions are.
Yes.
Otherwise, if you're thinking chemo, maybe the fuse is platin. But overall, generally speaking, the response to radiation would be way better than what you get with chemo. But if that is not an option, then you're only left with chemo. So
yeah, I agree with you. In fact, the only problem is that patient has refused to go to KNH. Eh? And any other place which is not KNH has cost implications. That means that if they're going to Eldoret, then they have to pay on top of that NHIF. So those are things that she needs to know. So I would agree that radiation is always number one for squamous cell metastatic, locally advanced. But then if you can't afford and does not want to go to MTRH, then you're stuck with him.
Yeah, so surgery is definitely not an option.
That's true. That's true. I agree.
Did you say she has now agreed to go to KNH?
He's not agreed to
Not
go
yet.
there, but I think he can try and find funds. He was saying that he needs to pay about 300,000 in advance, which will take him time, but I think he can try.
It's metastatic, isn't it?
Yes.
Basically, it's palliation. Palliative intent. So,
Yeah, because that's another thing. You also don't want the man to sell all his houses and shambas, and then you're not going to cure him.
Yes.
so we should send to the oncologist, isn't it?
Yeah.
I think
And
so.
dermatology.
And dermatology for the skin disease. Because we don't know if those are pre-malignant lesions or, isn't it?
So it's been 13 years now.
Sorry?
As in, since the time it started, he said it's been about 13 years.
13 years.
Since the first time he saw the first lesion.
And the tumor?
The
How
tumor
many years now?
since 2015.
Okay. We need to know what they are, even. So we send to radiology for further management, isn't it? Yeah.
I think that's a consensus, radiation for her. That's the first choice.
Yeah.
If she can't afford, then that's the time you'll think about chemotherapy.
So, Dr. Shah, it would really help if instead of writing on the file to send for radio oncology, just get Dr. Opaka's number. You try communicate to him and then talk to the patient. If they are not ready for radio, we just come up with a plan in the course of the day of whether we may need to start on some form of treatment and then cancel on the prognosis.
Okay.
Who is sharing? Maybe we should go to the next case.
Okay, so I'll present the next case. Dr. Klaj from MTRH. So it's a case of patient in the clinic. Born 1985, is a male patient, born 1985 from Nairobi. So this patient presented to us in 2014. At that time, the patient is RVD, non-access on heart. He has been compliant on the medication since 2012 when he was diagnosed with the HIV. So in 2014, he presented with history of left neck swelling. So this was there in 2014. So I'm saying 4 years because up to now it still has the neck swelling. At that time, it was just a neck swelling on the left side, which was a cervical adenopathy, and he did not have any other symptomatic symptoms like hotness of body or night sweats, and also he had a left. So CT scan and biopsy were done in 2014. Okay, the next. Just a few minutes. Wait for the things to be sorted. So the CT scan showed the left supraclavicular mass, which was I think around 5 centimeters. And a biopsy showed, oh yeah, there we are. So the next slide. So that's the CT scan done in 2014 at Kijabe, which showed a well-defined 56 by 50 by 30 millimeter soft tissue mass arising from the left sternocleidosteroid muscle extending superiorly to the left sternum and the left cervical adenopathy from level 2 to level 3 nodes. So they were thinking of maybe it's lymphoma or adenitis, to be adenitis. And then a biopsy was done. The biopsy was reported here in this facility, which showed reactive lymphadenitis, consistent with Castleman's disease. And they recommended to do HSSV8 to see. It was done, it was negative. Sorry, it's not so clear when you're doing the photocopy, but it was negative. So the patient was managed as Castleman disease and was started on high-dose steroids at 1 milligrams per kg, which he did for around 3 months, and then it was tapered off. At that time, the patient responded to the steroids, though the cervical adenopathy did not completely subside. Afterwards, he was lost to follow-up because I think he comes from Nairobi, so he went back. So I came again in April 2018. This time he was admitted with the recurrent cervical swelling, which was on the left side, and it was so huge, it was causing obstructive symptoms. He could not turn the neck, he had difficulty in breathing, he had dysphagia, and he also noted to have a left-sided pleural effusion, which was drained in the wards, and abdominal swelling, and noted to have hepatosplenomegaly. He also had now hotness of body and drenching night sweats and weight loss. So we reinvestigated him again, and we did, this was his workup. Noted he had an anemia of 6.4, the white cells were 6.3, and the pressures of 591. So the patient was transfused. A lymph node biopsy was done, which showed reactive lymphoid hyperplasia. BMA was done also. It was reactive marrow. There were no features of malignancy. The blast count were normal, 4%. So CT scan of the abdomen and pelvis. If you can see that the patient has multiple enlarged lymph nodes, largest 3 by 8 by 2.7. There are nodes in the abdomen, there are nodes in the iliac region, and also there are mediastinal nodes, and there's hepatosplenomegaly. So the radiologist was thinking it was consistent with the lymphoma. So because of all these symptoms that the patient had, the lymph node biopsy did not pick any lymphoma that we were thinking at that time. So we decided to go ahead and treat the patient as Castleman's disease, but this time with chemotherapy. So we started him on CHOP regimen after the stabilization that has been done in the wards. And the patient really responded very well. And actually the lymph nodes reduced, the patient was able to breathe well, the spleen and the liver are subsiding, and also the lymph nodes are also subsiding. So currently the patient has done 3 cycles of CHOP regimen. So the points of discussion, we just want to really conclude on this diagnosis because of this, we are still using like the first biopsy because of the second biopsy, it really did not pick, even if it was Castleman disease, but more of reactive hyperplasia. So to discuss this diagnostic dilemma, because we need to have a conclusion on what disease that he has, this lymphoma or is it Castleman disease, and something to note about Castleman disease for those who have not had it. So it's not really a malignancy, it's like inflammatory process which usually affects the lymph nodes. So you could have either unicentric or multicentric, where unicentric is one lymph node, and usually readings suggest you can do a excision of that lymph node, or multicentric. And multicentric, they don't have a specific regimen you treat as per the symptoms. So they recommend steroids, and also they can recommend for severe cases, you can also give chemotherapy. And because it presents almost the same way like lymphomas, they advocate you can give many centers give the same regimen as they do for non-Hodgkin's lymphoma. And then the other thing is if immunohistochemistry can be done on the sample, because one of the regimen also they were suggesting is also to do targeted therapies like rituximab. So can it be done in a sample that is saying a reactive lymphadenopathy? Should we continue with this line of management? Are we doing the right thing? Are we treating him well? He's responding, but are we doing the right management? And what's the way forward for the patient after the chemotherapy? Yeah. Can have some of your input.
Thank you. This is Lotardo. So I think I was able to see one of the first biopsy, and actually the features were those ones of an atypical reactive lymph node with features of Castleman's. And usually for Castleman's, we look for features like regressive follicles. Okay, and then what we call hyalinization. And also sometimes you get infiltration with plasma cells. So as Dr. Klacher said, we have some which are HHV negative, and there are those ones which are HHV8 positive. And the HHV8 positive are more common with the HIV, but this one seems to be HHV8 negative. So the issue of whether we are dealing with a lymphoma process or Castleman disease, as you have seen from the two lymph nodes, there were no actually features of overt lymphoma. But I think since we have antibodies, we can actually just do to confirm. But as Dr. Kibet had seen the other lymph node, and not seeing any features of lymphoma. So, but just to be able to confirm and to be able to be on the safe side, I think we can be able to run some lymphoma markers, which of course would still respond to the CHOP which you have given. Maybe Dr. Kibet can comment.
Okay, the challenge about I would agree on the reactive part, given the long duration of the symptoms as well. 3 years, if it was really a lymphoma, it would have progressed pretty fast, and not like you're going to 4 years and the symptoms are still progressing quite slowly. So the thing is, Castleman, as Dr. Lotada said, is still reactive, a typical reactive picture. But then the challenge with immunohistochemistry is that when you're trying to do immunos targeting non-Hodgkin's lymphoma, like lymphoma, you need to see some suspicious or typical lymphoma cells that you'd want to mark with some particular antibodies, because typically in a lymph node you love your CD20 positive cells, which are small mature cells, isn't it? You love your CD3 lymphoid cells as well. You love your CD10 positive cells, germinal center cells. So in the absence of really target cells in which you want to see whether this sort of malignant cells are staining for CD20, CD10, or CD3, or even a Ki67, it becomes quite difficult because you could still do your panel of immunos and not get a good picture because of the absence of those malignant cells in which you want to test whether they're positive or negative. Because in reactive, you're literally seeing inflammatory cells within the lymph node, which are usually normal to see them in a lymph node. So you'll see some staining, but then the staining cells make plastic. It's the biggest challenge in this particular case. So running the immunos is not an issue, but interpretation and whether that interpretation will be useful or not is the issue, because I don't think it's going to be, unfortunately. But from the way you presented, it looks more of a multicentric Castleman, because there's a splenomegaly, there's anemia somewhere, and multiple lymphadenopathy. Okay.
Initially, it was unicentric, but currently now it's, I don't know, does it change? I'm not so sure, but it is.
Okay, good morning. You have a comment, Doctor?
I was wondering about the obstructive symptoms. How are they now?
Now he's not obstructed. He's able to feed well. He's able to breathing difficulties and subsided. Like I said, the lymph nodes are regressing, so it's currently now stable. But ECOG actually 0. Yeah.
I think also from literature they say the HHV8 positive may transform to KS, Hodgkin's disease or non-Hodgkin's disease in some few cases. But I think for this case, I don't think that's the case because we would have picked it at least from the second biopsy.
Okay, my name is Dr. Beatrice from NTRH. I think what my colleagues have put forward is really basically a summary of how we manage Castleman's disease. When we, Castleman's disease, we treat it, ideally you should look at it as a benign condition, but the multicentric one almost behaves like a malignant disease. And looking at our patient here, it is possible, Dr. Kilach, that in 2014, maybe it was a unicentric Castleman's disease, because from the CT scan, actually it was a single lymph node area which was involved. And usually, like you saw, they gave steroids and he responded. Although usually steroids, you may respond to the constitutional, even unicentric, the patient can present with the constitutional symptoms that we see here, but they are not as significant as multicentric. So if you give the steroids, the patient will respond. The size might shrink, but it might not disappear completely. And management is actually surgical. You should go and remove everything. If you leave anything, it leaves room for continued growth. So I think maybe at that point we missed an opportunity. There should have been a role for surgery to try and remove it. It is not clear, even in literature, whether unicentric can continue to grow and become multicentric, or there are two different diseases. But this time around, he's presenting more like a multicentric Castleman's disease. And like you rightfully mentioned, it can either be HHV8 positive or negative. Making an assumption this time round, although our diagnosis this time round is reactive lymphoid hyperplasia, it seems that they did not see the pertinent signs of Castleman's disease. But there's also HHV8 negative. Actually, it's called idiopathic Castleman's multicentric Castleman's disease. And you can still have, although the common one for those who are HIV positive are HHV8 positive, like Dr. Lotodo mentioned. Yeah, but you can still have patients who are HIV positive and they get the idiopathic, the multicentric Castleman's disease. Yeah. So when it comes to diagnosis, like it has been mentioned by our pathologist, it can be actually a diagnostic dilemma, differentiating between whether this I think it's more of a morphological diagnosis, isn't it? Yeah. If you don't see the pertinent signs of lymphoma, then you are stuck between differentiating between a reactive hyperplastic lymph node and figuring out whether there's Castleman's disease in there. She mentioned those things that I don't know, they're called hyalin and plasma cells that you might see in there. Yeah. And but I think maybe for our patient here, they didn't see those things. So it's interestingly, he has constitutional symptoms. So what do you do? Yeah. I think it was a question of whether you continue giving I don't know, some drugs to just manage the cortical symptoms, go ahead and give CHOP. In terms of management, there are different ways you can approach it. Like you said, one, of course, is using chemotherapy regimens, which are CHOP and CHOP-like. And also, there's a role of rituximab. Rituximab is not really targeting the CD20. It has just been shown that you're going to improve on it. And that's why even if you probably do the CD20, it might not be positive. Yeah, but they do respond to it. One of the things that these patients produce is interleukin 6. And interleukin 6 is it's actually a marker that gives you those constitutional symptoms. Yeah. So when you get the rituximab, it has been shown that those kind of symptoms they go down, and you can also use antiviral agents. Yeah, but acyclovir and those ganciclovir. Yeah, but our access to rituximab has improved significantly in our setting, but we are not there yet. So I think we are still very friendly with CHOP. Yeah. So as to the question whether this patient should continue with treatment, I think I would say let's continue. I don't know, since our pathologists are not able to commit to tell us 100% whether we are dealing, but the patient is improving on it. Should we pull back or not?
Thank you.
One of the questions asking us about how many cycles should I go
6.
when I finish, what will happen next, and not answer some of the questions that he was asking. So I said we'll monitor with the response.
There's something about how you sample the lymph node. Is it possible, maybe, unless if you do the whole lymph node, are you likely maybe to get more information compared to just taking a piece? Would you guarantee maybe have they completely resolved the lymphadenopathy? Dr. Kilach?
I think these were whole lymph nodes.
Okay, good.
But there are small ones.
Mm-hmm.
I told him the possibility of likelihood of a repeat he was not for the idea, because I think this is the third time that he has been done. And it's because the first one was done in Nairobi before it came, and then we had the one which was done here, and then there's another one I think which was done at Kijabe, which says still picking reactive, so it was not up for the idea of a repeat.
I think people were trying to look for lymphoma.
Yeah, I think people, yes.
Which we are not finding.
What we could do is probably I show around as well, and probably do multiple deeper levels for this particular one. See whether the pictures, those pertinent things, the onion skinning, myelinization, plasma cells and stuff can be picked from this particular one, so that it doesn't just remain reactive, but reactive consistent with our customer. And then we see, because for sure there's no lymphoma here.
Okay.
We are, as Dr. Kibeta says, we can do deeper, but I think from the 2 or 3 lymph nodes, we are more or less convinced that there's no lymphoma, and we are dealing with carcinomas. So I think the question is that for lymphoma, you have a cycle of treatment, but for carcinomas, when you stop the treatment, those lymph nodes will recur. So I think it's an issue of maybe asking people who have more experience on how they handle this. Yeah.
Can I make a comment? Sorry. So, Dr. Beatrice, thank you so much for bringing up the issue of interleukin 6 protein, which is a cell growth factor that causes the overgrowth and contributes to the development of Castleman's disease. So the other drug that we could use to block the interleukin-6 protein that we have available is thalidomide. And I think there are some studies which have shown a good rate of remission induction using the thalidomide. So just to put it out there. But otherwise, I think treating his HIV better and the antiviral agents, as you said, that would be just fine.
Okay, thank you. I think now, if it was just a reactive lymph node, we probably wouldn't have, those other symptoms. Like he has the anemia. Did he have thrombocytopenia too? He has hepatosplenomegaly. So the likelihood that it is Castleman's is probably high. Now, if you are to make there's a group which put up the criteria for diagnosing idiopathic multicentric Castleman's disease sometime last year, and the criteria was, one, you should have a histopathological diagnosis, which is distinct of Castleman's disease, and then the multicentric picture, and then now 2 criteria from those. I think there are like 11 criteria, which I'm sure quite a number of our patient has. Yeah. So I think we probably have, we are not able to have the histopathological diagnosis. We have the multicentric picture, and we probably have the 2 criteria. 3 out of 4.
But I still believe we still have the histopathologic diagnosis of Castleman's. That was
the initial one.
Was not treated completely.
Makes sense. Okay, good.
Actually, if you informed us early, we could get you pictures and show you
To differentiate.
Yeah, what is reactive and what is what are these
Thank you.
features of customers. Yeah, we could put them in the PowerPoint, and then you could be able to appreciate. Yeah,
We could do that in the next.
Yes. Let's do that in the next tumor board. So I think we continue treating the patient, maybe up to 6 cycles of CHOP. Yeah. And hopefully it gets into remission. If it comes back, we'll think of plan B. I think there are more options for him.
Thank you so much for the contributions. I think we can go to the last. I think some have a case. We'll hand over to Dr. Ganda for the case.
Yeah, thank you. This is actually a case from our region. It's not from Kisumu directly. It's from Migori. Amy is one of our colleagues. She studied in the US. She runs an orphanage. Called what? It's a clinic or a hospital which takes care of patients from children's homes and from orphanages, those ones who can't afford and who have chronic illnesses. I think I want to her to present her case. I don't know where she is. Amy? Hello?
Hi. Can you hear me?
Yeah, we can hear you.
Okay. Do you have the slides? I have them with me, but it says that something is sharing on my side. Here it is. Okay.
Yeah, the slides are on already. You just need to talk.
Thank you. Okay, so Sure, absolutely. So, Amy Hera, I'm U.S. and I'm also the clinical officer here in. Today I'm going to talk to you about one of the cases that as Dr. Ganda said, we specifically take care of orphans and vulnerable children here. So one of the things that gets complicated is the medical history, and you'll see that. So this is a child who had extremely advanced retinoblastoma. However, she had never seen it she came to us. A police case, and so there was not a lot of medical history. First, they said that this had onset 3 months ago, but after talking to the parent alone without the police, she admitted that it actually started appearing 2 to 3 years. The patient, WJ, is a 2-year-old female. Let's see. And you can see there, let's see. Can I change?
Next slide. We are losing her.
Sorry.
The
I
other
was
slides.
trying to see the next slide.
I'll just say next slide. They'll move them for you.
Okay. I think it's a little bit delayed. Okay. Okay, perfect. Yeah. I have the next slide. So, yeah. So this patient, we took her to Sabatia Eye Hospital in Vega. We saw one of the eye specialists there, and her diagnosis was simply confirmed with the ultrasound there. We've not done pathology yet. But he had advised, because that we found on that ultrasound of the, that we do a CT of the head. In addition to the tumor findings, this child has a 3 centimeter lymph node right in front of the rear. It's like the rear. She has relatively severe pain when she's not controlled. There's good days and bad days, but the pain has definitely over the last few weeks. So controlling that on oral morphine right now. The child is vomiting almost daily. The tumor, I think, is one of the most notable features. It's just growing before our eyes, so it's extremely purulent. It smells, it's bleeding, and if you were to take a picture of the patient daily, put them all beside each other, you can just see so much change in the tumor. Overall, with the pain control, with the morphine, this is extremely energetic. She's not lethargic. We have a lot of other children here, and she's always playing. She attends we have a little school here to help the kids maintain their classes when they're sick. She attends the classes. She does daily activities, so she's actually doing extremely well, just apart from the headaches and the vomiting, which doesn't seem to faze her. She'll go to the restroom and not even tell us that she's vomited.
Next slide.
So after we went to the hospital, we saw that there was metastasis to what they said was the sella, the frontal lobe, and they said the medial temporal lobe as well. And from that, the who we had gone to consult about enucleation that it would not be advisable based on involvement alone. So we were prescribed VEC. He said just to do 1 round of that chemotherapy for palliative purposes only, just to shrink the tumor and to make her more comfortable. Here I have the report. You can see the size of the tumor. Yes. And so the radiologist had suggested that we do histology. However, the physician had advised that we don't do anything except palliative care, that from what he had seen, that was what we should do forward. You can see was the calcifications that we saw on the ultrasound of the eye that was done at, and then on the last report is just an abdominal pelvic ultrasound that shows that the patient did not have any to the abdomen or the pelvis. And then 12 slides, the CT scan. The reason I include this is because we have had some different opinions on whether or not this child would be a candidate for radiation surgery rather than systemic chemotherapy. So I posted these images just so some of you all could take a closer look and just give your opinion of how it's seen in these images. But yeah, so in summary, that's the big decision we want to make right now is, do we start that chemotherapy as it was prescribed, expecting only palliation, or do we do the radiation and surgery hoping to cure the patient? Thank you.
Hello?
Yes, I'm here.
Okay, fine then. I'm asking if the
Can
other
you hear
team is...
me?
Yeah, I can hear you. I don't know about the other team. Why I wanted us to present this case is that the tumor seems to be arising from somewhere in the eye. I don't know what it is. It seems to have infiltrated into the brain, but it's still local. It hasn't metastasis really. We don't have any distant metastasis. So I thought maybe the medical and radiation oncologists be able to give a hint on what they should do.
So unfortunately, don't have any medical radiologist oncologists present today. But I think we can have a talk with them and then see what the input is. Like I've said, maybe there's no so much distant metastasis, and we can be able to see if radiation can help. Although maybe at this point, maybe cure might be a bit of a challenge because of the size. Yeah.
Sure.
Can I make a comment?
Yeah, please go ahead, Monique.
So thank you so much for the presentation. The reception wasn't so good. I may have missed a few points. But anyway, patients with retinoblastoma may respond well to chemotherapy and complete surgical excision if possible, and external beam radiotherapy. Usually what is recommended for chemotherapy is vincristine, etoposide, and carboplatin, which I think is what the other team had suggested. My recommendation would be to go ahead with that, because what has been shown to have good response is if that chemo is given first as a neoadjuvant, and if possible afterwards, the treatment is followed by complete resection of the tumor. If complete resection of the tumor won't be possible, then radiotherapy can be considered. And the reason why radiotherapy kind of comes towards the end of the treatment is because of the effects that it has in the surrounding structures. But we'll consult more with the pediatric team. However, I'd suggest that we continue with vincristine, etoposide, and carboplatin, which is what has been demonstrated to be effective in other centers.
Thank you, Monique. I don't know, do you take a biopsy for these tumors? Usually get histological diagnosis?
That's a good question. I probably missed that point, but we need to have a diagnosis.
Okay. So you'll get back to us once you've done your consultations. Is that what we're saying?
Yes, we will, but if maybe instead even can take a piece of just a biopsy, I think we can get something so that we have a conclusive histological diagnosis. Maybe enucleation will not be, at this point, maybe the surgeons will not do, but they can do like a core biopsy of it.
Yeah, that is true.
Yeah.
I agree with you.
Consult.
Fine. Thank you very much for the input. I think that will be all from our side. Unless someone else is commenting.
Thank you. I think I've come to the end of the tumor board discussion, so we'll be able to maybe give way forward for the two cases that we do not have a conclusive points. Have a great week. See you next week.
Okay, thank you.